Hi, my name is Jared Rouse. I'm one of the vascular surgeons at the Cleveland Clinic, and I'm going to be talking to you briefly about the basics of transcranial Doppler, sort of the need to know for the RPVI test. I want to give special thanks to Larry Raber, who's one of our vascular techs and the manager of the TCD clinic for the majority of the slides and content of this talk. So transcranial Doppler has many benefits. It's non-invasive, it's portable, painless, it's proven safe, and it can be used at bedside, operating rooms, and even in the angio suites. It's relatively inexpensive. So TCD, it sends ultrasounds to the acoustic windows in the skull. It's 2 megahertz. You obtain spectral waveforms. You can measure the velocity of the blood flow, identify the direction of the blood flow. What is it indicated for? So it's cerebrovascular disease, intracranial stenosis, subarachnoid hemorrhage, particularly looking at vasospasm, can be used in brain death declaration, and also can be used in sickle cell disease. It can also be used for emboli detection, so continuous TCD, usually done in 30-minute intervals. Assess for right to left shunts, collateral pathways, assess extracranial disease. For example, if there's dissections or occlusions in the extracranial disease, it can look at the effect intracranially, and in acute stroke. So obviously the circle of Willis is how a lot of this is able to be done. The main focus and really the focus of the TCD exam looks at the anterior communicating artery, the middle cerebral arteries, the basilar artery, the left vertebral artery, and the posterior communicating artery, as well as the carotid siphons. So, as we know, the circle of Willis receives blood from both the ICA and the basilar artery. It communicates via the anterior and posterior circulation, which protects the brain during obstruction or changes in flow patterns. The communication is achieved by both the anterior communicating, or the ACOM, and the posterior communicating, or the PCOM. Transcranial Doppler can be used through 3 separate windows: transorbital, posterior, and transtemporal. The mean flow velocity is what's used in transcranial Doppler. It's the least dependent upon systemic factors such as heart rate and peripheral resistance. It's a higher correlation with perfusion than systolic or diastolic velocities. It's highest in the MC, or middle cerebral artery. It's variable in the anterior cerebral, and it's lowest in the posterior circulation and vertebrobasal system. So these are the values that are sort of made simple, and these are the ones that you can kind of give you a heads up on the RPVI. MCA is 60, ACA 50, PCA 40, basilar 30, and vertebral 20. There's ranges for each of these, but if you can remember these values, you'll be pretty close for most of the test questions. The other important thing that's different for the TCD test is pulsatility index. This describes the shape of the waveform. It's an indirect assessment of the proximal and distal resistance. So a normal pulsatility index is 0.8 to 1.2. So when you see increased pulsatility, this could be proximal to a stenosis or occlusion. It can be seen in increased intracranial pressure and in microvascular disease. So this is an example where in the basilar artery, you can see the pulsatility index is increased to 2.7. This is proximal to a stenosis in the basilar artery. Lower pulsatility can be seen in the stenosis of the supplying artery or in AVM features. In this example, you can see here the internal carotid has a high-grade stenosis slash occlusion on the ultrasound. And you'll see a low MCA pulsatility, as can be seen here. So in the MCA, you can see the pulsatility index is 0.5 versus 0.86 in the right MCA. So on the TCD exam, so there's 3 windows. The transtemporal window is the first. You can see the MCA, the ACA, and the PCA through these windows. The MCA is at a depth of 45 to 60 millimeters. Direction is towards the probe. The window, again, is temporal, and the velocity is 40 to 86. ACA to MCA ACA bifurcation is bidirectional flow at 60 to 65 millimeters and in the temporal window. The anterior cerebral artery is at a depth of 60 to 75 millimeters. Direction is away. The window is temporal, and it's again 41 to 76 centimeters a second. The posterior cerebral artery, or P1, is about 65 to 75 millimeters. Its direction is towards the probe, and the velocity is 33 to 64. On the next window you can use is a transorbital window. You can look at the carotid siphons and the ophthalmic arteries. The carotid siphon is 60 to 75 millimeters. The direction is away, towards, and by, and the window, transorbital again, the velocity is 50 to 60 centimeters a second. So as you can see here, depending on which part of the carotid siphon you're in, you can get different directions of flow. So in the paracellular, the direction is towards the probe. In the genu, it's bidirectional. In the supraclinoid, it's away. And the ophthalmic, it's towards. Again, the ophthalmic artery is seen towards the probe in the orbital window. The transforaminal window, or posterior circulation, so you can see the basilar artery and the vertebral artery. The posterior circulation, again, look at the basilar artery. You can see this is a depth of 80 to 120 millimeters. Direction is away at a velocity of 30 to 57. Looking at the intracranial vertebral artery, so the depth, again, from a posterior view is 60 to 65. The direction is away and 20 to 55 centimeters a second. When you are looking for emboli, you can use bilateral MCA monitoring with the TCD, so the transforaminal window, and you can see the emboli during the exam. These are typically done in 30-minute intervals, and you will actually, the machine will actually interpret a chirp or have an audible sound when there is an embolic event. So the TCD limitation, so there's operator dependence. Blind vessel identification, that means that most of this you're not actually being able to identify what vessel. You have to use the operator to help identify that, as well as looking at the waveforms and which direction the blood's flowing, which is why it's very important to pay special attention to the direction of the blood flow in the windows. That's really how you're going to identify the majority of the of which vessel it is, and that's pretty consistent on the test. I think a lot of the questions on the test will focus on the direction of the flow as in the different windows. So I would remember those. Vascular anatomy variants, and then in thick skull you won't be able to see the majority of these. So that's really all I have on the TCD basics. I think the main thing to remember is pulsatility index, as well as the depth and velocities and direction of flow for each of the vessels, because there will be questions on the test with that.